Welcome to the Wayland Wisdom Hub, your go-to destination for financial, operational, and business insights. I'm Jacob Corey, your host and guide through the stormy and often confusing waters of accounting, tax, audit, business management, and operations. Today, Lori Morgan will be interviewing Dr. Bez, a general dentist who made the decision to start a niche practice servicing patients that need TMJD and dental sleep therapy. Let's hear his story.
All right, so today we have with us Dr. Bez. Did I say your name right?
That's correct.
I tried to practice it. We're not going to call him that. We're going to call him Dr. Bez because he doesn't even know the answer to that anymore. He's been called Dr. Bez for so long. So the reason we wanted to talk to you today was because of your unique story, we feel like a lot of dentists could benefit from thinking about their next act. We have people in our clientele that are getting ready to retire, and they'll send me messages or emails and just tell me, I really need to talk to you, because we do some exit planning. We try to help people make sure that they're ready to retire, not just financially, but also, emotionally, physically. I'm ready to do this. What's my plan? And they haven't really thought about it. And before, just on a visit, I was very impressed with the fact that it seems like you started to feel like, I'm done being that, wet finger dentist, so to speak. I'm done being that, but I'm not done with dentistry. I'm not done with working or being involved in my career. So that's what brought us here, because we're gonna capitalize on your wisdom and just hear how you did it. And hopefully that'll inspire someone else who's kind of sitting on that fence right now thinking, what am I gonna do next? So first I wanna know, how did you even get involved in dentistry? Were you from the age of 5, I wanted to be a dentist, or was this something that happened later in your life?
No, it kind of, I went to University of Akron, and I was in the normal pre-med, pre-dent stuff, and, eventually going to be a physician, but then had a friend that he was in dental school. He was in that fraternity, actually, and he kind of said, you might want to consider that. So that's what I did. And I came down, actually, I got down early into Ohio State, and that was the year in 1973, I guess it was, that we had the 3-year program, and we were the very first class that went all year round, so you did 4 years in 3. So that was kind of neat, so I kind of did that, and I enjoyed the dentistry part of it. I liked the problem solving, I liked the patient flow and that kind of stuff. So I did that, and then I went in the public health service for 3 years, the U.S. Public Health Service. I did a residency in Seattle, and then we went active duty to Mobile, Alabama, and Detroit, Michigan. And then in 1979, we came back here, and I'm from Akron, my wife's from Cincinnati, so we liked Columbus, and that's where we had originally met. And we started to practice from scratch. You don't do that too much anymore. I don't think hardly at all. I mean, we just there was a building there, and we said, okay, let's go ahead and start that. So in July of 79, we started that. Now, fortunately, I had some contacts at the university, so I taught general dentistry, operative dentistry for about 9 years. So that really helped the initial time, because I was down at the university 2.5 days a week, and then I go to the office for the other couple half days and weeks and that kind of stuff. And then that gradually morphed into when the university started to cut back in the about late 80s, I guess. Then I pared down to just 1 day a week, and then eventually I didn't have to go in to the university. And I really enjoyed that. That 1 day a week, as you can attest, we always, when I was in school, the 1 day a week wet finger dentists, we used to call them, they came in 1 day a week, and we really liked working with those guys because they could really give you a sense of what it's really like in the real world versus what it's like in dental school. So that was really good. So I enjoyed that. I loved going down 1 day a week. I could probably do that more, but we ended up having to run the practice, and we gradually grew the practice quite gradually. And actually at one time, the modus operandum in the 80s and 90s was, you had one hygienist, and then you had 2 hygienists, and then
Yes.
you grew your practice, and that was great, and then you got an associate, and that was great. At one point in time, I think we had maybe 13 staff members, including associate dentists. The fact is, I didn't prefer that. I didn't like that. I didn't like running that big type of a practice. So that's a long story short, but we pared down to basically just myself and 1 hygienist and 1 or 2 staff members. So we went small again, which I really enjoyed, but that led to what do we do next, that kind of thing. So I was always interested in restorative dentistry. That's what I really liked. That's what I taught down at the university. But I always built that along with the TMJ things. And in the 80s and 90s, Pete Dawson and Pankey Institute, that kind of stuff was really good. I took a lot of courses there, and I really enjoyed those courses. I'm kind of a CE crazy guy, but my wife always says you go learning all the time. But I really enjoyed going to those CE educational things. It's kind of sad now because everything's done online so much, and I think you really miss out on going and meeting with other doctors and the individual one-on-one personal relationships that I've met all over the country is really, really nice. And so that was hard to do because you had to, get out of your practice. It costs a little bit more.
Absolutely,
because, the tuition wasn't quite as much then as it is now. But, you're out of your practice. You're not making any income on that day or two, but you're learning things to put back into your practice. And that's what was very, very important to me, especially with Pete Dawson. That was great. So we used that base knowledge for our restorative practice all through my entire career. And then about, I suppose, late 90s, early 2000, I kind of started thinking, we were doing more major reconstruction cases, full mouth rehabs, things like that. So I was really kind of wondering, we got to really focus in a little bit more on TMJ because that was maybe more important than a single crown or small bridge, things like that. So let's see, how did he do that there? I started getting in more in TMD and started taking some courses in TMD, and I found myself on a company called True Denta, which was very unique because they had some tools that were able to take the educational academic part of TMD, which I always found was difficult to kind of apply directly from the classroom to the patients from a standpoint of TMD takes a lot of time spent talking with the patients. And when you're in the busy dental world, you're moving from a crown to hygiene to whatever, and you just don't have a lot of time to do the TMD. And that's, I think, why a lot of dentists don't do that, because it does take so much time to foster that. So the goal was to kind of do the TMD, and then that would help the restorative, because if you treat the TMD, then many times the bite has to be adjusted, so that marries into the dental part of it. And that was my original thought. And that helped out quite a bit, actually. But what I really found was it wasn't that so much as it was when I were doing TMD patients. We found out that, boy, a lot of them had sleep problems. And we started dabbling into that a little bit in the early 2000s and stuff, and I started taking some classes on sleep dentistry, because those two things are very intimately related. If you don't sleep well, you don't breathe well, then you're going to grind and clench your teeth, and that affects the dentistry part of it. So I started taking more and more courses in sleep, and I really enjoyed that. I really liked that. I found that was something I really, really liked. Not that I didn't like dentistry, but it was kind of a little bit different. So that kind of spurred me on to kind of be thinking about doing something a little different. So took more classes and became a member of the American Association of Dental Sleep Medicine. They had a program to get a higher level than just the qualified dentist. That was a diplomat status. So I went through that. That was a pretty rigorous program. That was probably the hardest thing I'd done since dentistry. That was a 2 or 3 year project that we traveled across the country, and we learned how to do sleep dentistry. And my mentor here in town was Metz. That was very good. We started out actually with him, and then got into ADSM at his urging. And basically we started to do all of that, and we started to do more TMD in the dental office and more sleep in the dental office, which becomes a problem. Becomes a problem for any dentist that were thinking about doing that, because you got to wear a dental hat, and then you got to wear a medical hat, because TMD and sleep is more of a medical condition versus we treat it dentally.
Yeah, it's just like divert for a moment. When you are, like you were saying, the pace of dentistry, it's almost like those two things are warring for your attention, because you really need time in the chair to talk through what's going on with the TMD and the sleep. And at the same time, the hygienist is going to be like, I need a check, I need a check, and you've got crowns to cut. So is that kind of what made you be like, I'm going to have to kind of choose, or was it tiredness of being in the chair? How did that kind of evolve then?
Yeah, exactly right. That was a little bit of a war between dentistry and medicine, and your time and you can't do a good job at either one. So I didn't do this, but I'd recommend to anybody who's going to do it that maybe if you're still going to do your dentistry, which you have to do to kind of keep that going to start the new one, but maybe you got to say, okay, bite the bullet, 1 day a week or 2 half days a week, no dentistry, I'm going to do just sleep. And just do that. And even if you don't have a patient or two, that's always a good time involved for learning and teaching your staff and that kind of stuff.
Well, yeah, because that's a whole different, for the staff, that's a whole different experience.
Whole different set of skills that they have they have to learn. So there's quite a bit of learning that goes along with that. I didn't do that, but you're right. I kind of worried on that, and finally I got to the point where, what am I going to do? Do I want to retire? And I really wasn't old enough to retire at that time, even though I could. Maybe wanted to, but I really didn't want to because I like to have something to do. So we sold the dental practice, and then we just went cold turkey with the sleep and TMD. I should back up. How we got patients when we were in dentistry is that, we had some series of questions, and we asked the hygienist, make sure you ask people, do you snore, and do you have any breathing problems, and anybody with high blood pressure and things like that, are they sleeping well? And that's how we originally kind of introduced it to our patients of our general dental practice, and then those became sleep people or TMD people at that point in time. So that was a good way to kind of gradually work into it. I was amazed when I was doing general dentistry. If the dentist or the hygienist asked somebody, do they snore or do they have any sleep problems, you'd be amazed at how many of your dental patients say, well, I've been on CPAP for 10 years.
It's so odd, isn't it? We don't ask some of those questions. It's the weirdest thing because I don't know how we got the idea that the mouth isn't part of the body, but it's kind of like there's this, that's my line, stay in your lane. You stay in your lane and don't cross over.
Exactly.
And it's just funny because it's all, and we find out more and more all the time, right? That it's more and more related.
Well, and patients too, they don't think to tell your dentist how they're doing about sleep. They don't see the connection at all. So that was very eye-opening when I was still doing dentistry and trying to urge people to kind of get some thoughts on their sleep. And we had some pulse oximeters, so we send them home with a pulse oximeter, and we'd evaluate that, which isn't really a sleep test, but that gave us a couple red flags, and then we'd refer them to the sleep doctor, and then they came back to us if they didn't want to use CPAP and do an oral appliance. So that's how you kind of gradually walk through the process, but it does take a while. And even when we totally devoided ourselves of the dental practice, then we just went with the sleep and TMD. And that's, again, a good time to kind of, because you're starting out pretty much from scratch, like I did when I was in 1979, but you basically have to go out and visit the physicians and visit the sleep doctors and put your name in there. That's why I think the diplomat status in the AADSM was important, because the physicians like to know that you know what you're talking about.
Oh, sure, yeah.
So some credentials behind you are really, really important from that aspect. And so the first couple of years, I have to admit, they were a little rough, so, we made sure that we had that little nut of the sale of the practice. We used that sort of pot of money to kind of use that to kind of get us through the first 6 months or 8 months or 9 months. So.
Well, everything always is simpler in your brain than it is in actuality. You always have to kind of find your way. At least me, maybe I'm just telling on myself and you're perfect, but I always am like, this is a good idea. And then when you start implementing it, and I'm a pretty meticulous person. I plan this out. And I always find that all the parts I plan for other people work out just fine, but the part I had planned for myself doesn't have quite as good a plan. Yeah.
You got to be flexible, that's for sure. And I'm not as flexible as I probably should be, but you have to do what you got to do. And so that took a lot of extra effort. And we did that, and it worked out very well. In fact, we were doing really well, and then COVID hit.
Oh, yeah.
And actually, that was kind of good because it made us step back, and we had extra time to do extra training. We never really closed because we had sleep people, and their appliances would break and things like that.
Well, yeah, you got the excuse to actually see them, legitimately see them.
We had to be there. Right. We pared our schedule down like everybody, but we were always there. And especially TMD, because COVID was very, very much a stressful thing for a lot of people with temporomandibular joint disease. So we were getting a lot of calls for that. And then actually after COVID kind of boiled down, that's when TMD really took off, because people had been wearing masks for a couple of years, and teachers particularly, they were having all sorts of problems. And so actually our practice even became bigger following COVID.
So that kind of makes me wonder then, you said initially, like any smart person, you went out and talked to the people that you're like, I need your referrals. This is what I do. But as time went on, I wondered about that this morning. I had written myself a note. Did you start to see that your practice was turning into where people were seeking you out? Like, I'm just this guy calling, I wasn't referred to you, I just feel like I have this problem, you say you do this work, or did you still feel like things were kind of coming through your physician referrals, dental referrals?
Well, I think that's probably initially, yes, we had that, but they don't just write a referral right away. They have to have a patient or two come into your office and get some good results, and then you go back to them. But as time went on, yes, more people kind of found us online, and then they call, or as a result of dentists. Dentists don't like to treat TMD particularly. I mean, it's just not, like I said before, time-wise it takes requirements. So a lot of dentists, we get dental referrals. And then from our original patients that had sleep, then a lot of times, if the husband has some sleep apnea, oddly enough, the wife sort of kind of gets mutual symbiosis there and ends up with some sleep
Probably because he snores and keeps her awake.
Well, that's true. And although most of the time people are in other bedrooms. That's the most common thing is I sleep in the other bedroom.
Yeah, I can remember moms coming in with little kids that would be grinding, and they're like, I can't even stand to have them on the same floor as me because I can hear their teeth, those little tiny baby teeth scraping across each other. So yeah, there's nothing like somebody interrupting your sleep to say, yeah, I love you, but get out of my room.
That's exactly true. So that's how we got, I would say, most of the patients. Then gradually the referral base came up, and I think we don't really do a lot of quote advertising, but the advertising that we do is when we get a referral from the referral dentist or physician, we send after the initial examination, we send a soap letter copy to all of the doctors that the patient lists, basically, even the chiropractors, and they get that with our brochure so that they've got a constant supply of, I can send it to Dr. Bez. And we do that, and then when we finish the treatment, because TMD treatment takes anywhere between 2 to 3 months, depending on how it goes, and sleep treatment might take a month or two, depending on how quickly we can make the appliance. But once we've got the appliance completed, we send them back to the physician for a follow-up, because that's the only way you can really tell whether the appliance is really working. So we send them back, and then we send a follow-up letter to the dentist and the physician saying, hey, now we have an oral appliance for somebody, or now the treatment has been completed for TMD. So those letters, and I still use snail mail, because I'm a big proponent of, it's kind of nice to get something in your hands that you touch. And we put a brochure in there, and so by doing that takes a little extra time after you've seen the patient. And I suppose that's what I found with TMD and sleep. You're in with the patient a certain amount of time, but there's a lot of extraneous time when you've got to work on writing your letters, and you've got to talk to insurance people and that kind of stuff. So there's a lot of behind the scenes work that you don't have in dentistry so much.
So are you billing this through, like with sleep and TMD, are you billing this through medical or dental or a combo? Or how did you find out all about that? Because that's, again, another thing dentists run.
Yeah.
If you say bill medical insurance, they're like, I cannot do it. So how did you navigate that?
Well, that's a pitfall for dentists. I think a lot of dentists think you can just do sleep dentistry and you just take the impressions. That's the easy part. It's all this behind the scenes work, including that medical billing becomes difficult. We use a combo, actually, of everything, because when we're doing TMD, there's a few dental appliances that we can make. You can bill that through dentistry. The medical part of that, we bill through medical, although I usually tell patients don't think that TMD is going to be covered by medical, because it just fits in that little in-between, and most medical policies just don't cover it. So we usually tell patients, figure that they won't cover anything, and if we can get something for you, great. Sleep is the same way, although sleep is covered by medical, but you do have to file a medical claim. So we had to teach ourselves to do that. Now there are medical billing companies that will do that for you, so it can make it a little easier. However, you have to be very careful about medical billing companies, because they kind of bill for everything, and you can put your head on the chopping block if you're not doing the proper procedures and also billing properly. So, and you're the one that's liable for that, not the medical billing company. So that's a little scary thing. Now, I'm kind of a rogue about that. Even in dentistry, I never was a insurance provider. And we always felt that the contract for dentistry was between myself and the patient. And I'm great you're having dental insurance, and we'll file it for you. We would do that as a courtesy, but you pay us and then you get reimbursed for your dentistry. And we use the same model for the medical billing also, except for Medicare. But even in Medicare, for sleep, we bill and patients pay us and then get reimbursed by Medicare.
So is this increasing? Is our TMJ problems and disorders and sleep apnea, do you sense that this is something that's becoming more and more frequent, or is this pretty much it's just certain people are not?
No, I think it's increasing because of the stress that we're in our lives. Although I think it's more just age factors, because as we go older, your airway is going to close down a little bit. So from a sleep standpoint, it's more of an age thing than anything else. But I mean, you think about this years and years and years ago, I'm sure we all had still sleep apnea, but it was not really diagnosed. And you probably actually had a heart attack or a stroke at an earlier age. So you may have had sleep apnea for a long time and didn't know it. I mean, that's one of the things I got into sleep because my father passed away fairly young and he snored like crazy, and my grandpa did and my uncle did, and they all had heart attacks. So there's a genetic component to that, but also if you're not breathing properly, you're going to be more likely to have a heart attack. So I think it's been going on for a while, but we recognized it in the late 90s and 2000s, and now you wouldn't believe the number of people that probably have some sort of sleep disorder breathing, which again, I'm always the thing where, how do they relate to TMD? Well, we used to tell people, you grit and grind your teeth because you're all stressed out. And there is some stress in there. But really, I think most of the research indicates it's really more of a breathing factor. Your tongue is going to fall back in the back part of your mouth, and your airway is going to get narrower, and the body doesn't like that. The body wants as much oxygen as it possibly can. You can live without food and water for a while, can't live without air.
Right.
So what does the body do while you're sleeping to try to make you so that you don't suffocate? Move your jaw around, side to side, forward to back. And that satisfies the opening of the airway. However, the teeth get in the way, and so we end up with worn down, flattened down, broken down teeth. And the muscles of mastication are the motor for that whole business, so they're working all night long, and then that can affect the joint.
It's like any kind of muscle, right? I mean, the more you exercise it, the tighter it gets. And
it's getting tired and it's working all night long. You getting into good sleep phase is really important, because when you get into deep sleep, that's where the body does its repair work. So we've got heart, lung, pancreas, kidneys, muscles, got to do some repair stuff. And that happens during deep sleep. Well, you can't get into deep sleep if you're not breathing properly. And so if you don't get deep sleep, those muscles are going to get fatigued, and particularly in the morning, they wake up and they're sore as heck. And
headaches,
leading to headaches, migraine headaches, that's a big factor. And even during the day, if you didn't get a good night's sleep, you're maybe not on top of your game, and so you don't feel very good. Those muscles are uncomfortable. And then it starts to get into chewing because those muscles tighten up and you can't chew very effectively. So I'm of the opinion that basically sleep, in fact, I'd say 90% of the people I see for TMD problems, we treat that and do as best we can. There's no cure for TMD. There's more controls.
Right.
And that's, we do our thing for the controls, but 90% of the people I see for TMD, the real spark that's lighting the fire is their poor sleep. So we send them to the sleep doctor somewhere along the line, sometimes first, sometimes in the middle of treatment, sometimes at the end after we've got the balance between the muscles and the joint and the teeth. And then we get them in for a sleep test, and lo and behold, they got some sleep disorder breathing. And then we do a sleep appliance, or they get into CPAP. But we're helping people get better because we're helping them think about how they sleep and their sleep positions and a few other things that go into that.
I read on your social site little blurbs that you put up about wrinkles and sleep, and I'm like, no. I'm gonna have to go to bed really early because I don't want I need more sleep. I don't want wrinkles.
It's not necessarily more sleep. I mean, 7 hours is kind of the magic number, okay? I mean, everybody's a little bit different. Their circadian rhythms are a little bit different, but the main thing is getting into the proper phases of sleep.
Well, and that's stressful too, because I'm like a 6.5 person in my whole life, and it's stressful when you read that you should be sleeping like 8 hours, and you're like, I couldn't sleep 8 hours if my life depended on it. So then you're stressed about sleep, which only makes you more grinding your teeth, probably, because you're like, now I'm panicking because I can't sleep right.
Yeah. Well, when I was teaching, and I always mention to the younger dentists, it says, if you see somebody in there that's only 30 years old and they've got flattened down teeth and they've got a lot of abfractions, you better ask them about something's going on in there, And yeah, we can put restorative stuff on there, composites, and rebuild the teeth, but there's some reason. And even when I was doing dentistry, didn't know that much about it. You put in the buccal composites, and after a couple of years, you're replacing the buccal composites,
right,
because they're still
snap right back out,
and those teeth are still wiggling back and forth.
Yeah, flex them right out.
They're
of
flexing. That's right. So they've got to figure out what's the flexing. And every dentist in America goes ahead and just puts a night guard in there and say, "Oh yeah, we'll fix your thing." There, well, that does help. That protects the teeth because you got plastic in there, so that's all right. The only thing is, I have a little problem where you could be making their sleep apnea worse, because there's nothing to keep that jaw from going backwards. So you put a regular sleep appliance in there. If you haven't really analyzed whether they have any sleep apnea, maybe they don't need a night guard. Maybe they need an oral appliance or CPAP, because their real problem is sleep disordered breathing or sleep apnea, and you're treating the symptoms, which is the wear and tear on the teeth.
Right. That just brings us right back to the fact that we really do need to get stuff like this needs to be getting into the mainstream of dental training, because we're still telling ourselves, I think I mentioned to you when we met before, I did a grand rounds thing between the physicians and the dentists when St. Vincent's up in Cleveland had a dental residency program. And it was like a joint thing. We were talking about integrating medicine and dentistry. Like, it is integrated, so it's time we started acting like it's integrated. And I was showing them some slides of a person who, the physician had been treating this person for a sinus infection, and it just wasn't resolving. And the person just happened to go to the dentist, and I don't know what the motivation was to take the CVCT that the dentist did, but they did take one for some reason, and there was a giant cyst up in the sinus, it had poked into the sinus. And when they cured the tooth problem, the sinus problem went away. And my point to that was, we have tools. We might discover something, and you have tools, and you might discover something. And instead of acting like, not my thing, go see your dentist, you should be able to at least speak intelligently enough and say, here's some things that might be going on. We're going to work in cooperation with your dentist, or vice versa. And it was so funny, because when I walked in the room, the physicians were over here and the dentists were over here. And I'm like, you just won't even connect with one another, right? Yeah. And the same with optometry. We have, I have some children who have had to have eye therapy, and I was a non-believer. I was like, that's the most stupid thing I've ever heard in my life. How could you train your eye to track across the page, right? Well, then when you see, this one's having trouble in piano lessons, and when they get their eye therapy completed, they're no longer having trouble reading the music. You got this one who is not a fluent reader, and when they get their eye therapy finished, they read like they're 17 and they're like 7, Mm-hmm. And it's like, same thing. You notice these things, those kids that would come into your office and then, and you're like, your adenoids are like probably ginormous, right? You can't breathe. And the parents have just accepted that the nasal sound to their voice. It's just amazing to me that we have trained people separately, yet the body's one. Yeah. And this just brings that back. We really need to get schools teaching.
Yeah, I think you're right. Physicians and dentists, it's always been a big chasm there, because you just went one way or another.
Right.
That's been good for us right now, because we work with a lot of ENT people here, which I never used to have to get with them before.
Right.
But we, and they're the same way, where, I'm glad somebody gets in to have their ear, nose, and throat looked at, particularly their ears, because we see a lot of TMD patients where, all right, the physician looks and doesn't really see anything with the ears and says, go see Dr.Bez for his TMD. And same thing, if we get TMD, okay, I want to make sure that the ears are clicked out, because I want to make sure that there's nothing weird in there.
Well, because you have
tumors or
somebody
something like
going
that.
through a stepwise process between people saying, here's what I would look at next. That's just the critical.
I think it is kind of getting a little bit better. If you look at the whole big scheme of things of holistic medicine, there's a lot of physicians that are practicing, more wellness stuff. And I think there is some gradual meeting, and I think we're coming to the range that, hey, dentistry should really just be part of medicine.
It should.
But it's probably not going to happen in my lifetime. It's going to be just a gradual process. So
Yeah. It's an interesting thing, though, because you do it makes you go, how did this get separated? I mean, because dentistry does have that technical aspect, and I totally get that. But it's funny. I mean, I can't tell you how many times I've had someone say to me, so you're not a real doctor? And you're like, it says so on my diploma. So I guess the state thinks I am, and Ohio State thinks I am, but okay. So what's next for you then? Like, how long, you gonna stay in this? You gonna dabble in this a while longer? Or do you have something else in the wings that you're interested in and you're gonna start?
Nah, I don't know.
Dr. Bez 3.0 kind of.
Well, I'm probably not going to start all over again. My son-in-law went crazy. He says, you started 2 businesses, and why did you start this second one from scratch? I said, well, I'm probably an idiot, but it worked out, But I don't know. I'm going to get to the point where, eventually you got to say, when is enough? It's a point in time. But that's one of the things that this has been very helpful in, because, as a general dentist, you're tied to your chair all day long, and of course every dentist has some back problems, some sciatica and things like that, and I had my share of that. It wasn't real debilitating, but I could tell that it's a long day at that dental chair when you're in. People don't realize how physical dentistry is, really. I mean, it puts a toll. Hygienists too. I mean, we don't all have the best position, even though we've been told all the ergonomics on that, but we don't do it, because you got to look in the mouth and see what's going on. You got to look, and the loops and the magnification has helped, but still that sometimes made it a little bit worse. But anyway, that's nice about doing sleep and TMD, because although I do sit at a dental chair, I don't sit there for 2 hours at a time doing crown and bridge prep, hunched over. I'm there really talking with patients. So you're kind of one-on-one sitting up, and then you go to your office and you're typing letters and things like that. So it's a different type of thing, and it's much less pace, because I don't have to go check hygiene every 15 minutes or something like that. So that part of it, I think, has really helped me to be able to go longer from a physical standpoint. Now, how much longer I go, I don't know. Another couple years probably. But if I enjoy doing it, I'm going to keep doing it. I only work 2.5 days a week, so that's kind of nice. And we recently got in another doctor who's a diplomat in the American Association of Dental Sleep Medicine, so that's kind of helped, so that I don't have to be there those days. So we're gradually doing that. I think we're going to keep doing that for a while, but eventually, the eventual thing is I'd sell this practice and then probably stop, I guess.
Then you're going to just golf.
I'm just going to play golf and attend soccer games and
right.
that kind of stuff. But till I get to the point where I'm just physically unable to do it, I'll probably do and even if I'd sell the practice, I'd like to be able to work it out so I could be a consultant and grandfathered in.
Well, I think that's a wonderful idea, and I was just going to say, what we need is for people to, instead of being like, well, I'm done, because of COVID partially, because, everyone always says, well, dental school was a lot harder when I was in there. But we do know that over time, because the basic science knowledge has just exponentially grown, they do less and less clinical stuff. Like they'll do fewer crowns to get out and so forth. And when we worked with our residents, one thing we found out was that they are uncomfortable. They're afraid. They don't have any confidence. So a lot of times they'll go from residency to residency just trying to feel like I'm capable. That's a big strain on them. I think it's an emotional strain. We worked with the residents at OSU. We worked at the Cleveland Dental Institute, Miami Valley Hospital. And they're afraid to be dentists on their own. They don't know what they should be able to do. They don't have a lot of confidence in their hand skills. They're not sure. They end up taking jobs that are kind of lots of hours for low pay. So they're disappointed right from the beginning. So we've met with, when we would talk to the residents, at one point my husband and I did this up at our office. We had a deal with OSU, and they would come and they would do 50 contact hours with us during the course of their residency year. and we would talk about what you said. Like, there's dentistry in the clinic, and then this is real life dentistry. And now they're listening. I mean, I know most dental schools have a program where they'll talk to you about business or whatever, but I kind of contend that that's presented too soon in the curriculum, because you're like, yeah. I've got to get through clinicals. I've got to get through these patients. I'm not even out of the pits yet, and I'm learning. I don't care. Jake, the pits are where you go in the basement at OSU, and you sit there with 200 of your closest friends.
Yeah.
And you spend, like, you're closer to those people than you are your spouse at the time.
You sit hours there.
You sit hours there, and I mean, you take these. They're like qualifying kinds of tests where you cut on these plastic teeth, which don't cut like real teeth, by the way. And like, I can remember watching my buddy, and I'm just like, you're cutting, you're overcutting your prep. You're gonna fail this, right? And you're just like, you can't say anything, and you're worried about yourself. You keep measuring. You have this little cat diet, and you measure all these things, and then if you are capable of passing the competency to get out of there, then you can go up to the clinic and work on patients, well supervised. The problem is I don't think we've helped them in that next step. They don't have enough experiences, and they're reluctant. There's a lot of litigation and stuff. They're afraid. I think older dentists who have experience should think about offering their services to help people understand that, because they're afraid. They don't know how to get started. They're afraid they're going to fail. They're afraid they're going to mess up. I do keep up with some research. I heard that less and less dentists are actually coming out of school and buying practices or associating at all. And many of them don't even want to put down roots. They're just like, I'm just going to go work in one of these DSO chains. And if I want to move to Vegas, I move to Vegas. And if I want to move to Atlanta, I just move to Atlanta. And then I'm not tied down to a practice, which impacts our dentists trying to sell, because you don't have anybody who wants to buy it.
Buy and stay
Right.
there for a long period of time. And I think, yeah, you're absolutely right. I mean, it's a mental change in the whole ecological part of patients, for that matter. I mean, I've noticed the last 10 years. I mean, I feel sorry for the generation that went through COVID and even before. I mean, you're right. They are very not sure where they want to go. They're not confident, and that's what you got to have. You got to have some confidence, and you got to start and do something. Okay, even if it may be wrong. You don't want to hurt anybody, but you want to be able to, on this sleep and TMD. You got to be able to start, and you can't talk about the imaging until you've actually been out there with some patients, and now they have to see how it works. But same thing with our training of our staff people. We do our treatments on each other, so that's how they can learn how to, this is how the massage therapy goes, or this is how the ultrasound works for the TMD, or I try to I don't make an appliance for somebody, an oral appliance for sleep apnea, that I don't use myself. That's probably the biggest thing that I would say. Most labs, if the dentist would call up to the lab and they'd say, can I send you impressions, can you make a appliance for me? You really should wear that appliance. And I tell patients, there's 50 different appliances, so I don't have 50, but I probably have 10 or 12 appliances that I wear, and they always ask, which one do you like the best? I said, well, I switch every 3 or 4 days depending on my mood, but I can tell them what these appliances feel like, and I think that's kind of an important you can actually say that with conviction to people that, hey, I wear these things, and here's what I can feel, and you'll feel the same thing. So that's really important.
And getting rid of that CPAP for some people, I mean, that's...
Oh yeah, that's 50% of the
liberating.
people that should be using CPAP, it's sitting in their closet, and they don't. Well, they're opening themselves up to a heart attack or a stroke. So the compliance for an oral appliance, you still have to wear something in your mouth, and every once in a while, not very often, but we'll get somebody that just can't do that. But you can put that in your mouth, and the compliance is really pretty good. And most of the time, once you start wearing it, you don't want to sleep without it. So I ask people, do you ever miss wearing your appliance? And you might go to bed one night and forget to put it in or whatever. And if your wife doesn't nudge you and say, put your appliance in, you might go a night without. And then I always tell people that's a perfect time that you got to assess yourself the next day. Say, how do I feel today? And most of the time they're going to say, I'm not on the top of my game. I'm not a 10 today. I'm about a 7 or an 8. Oh yeah, I forgot. I didn't wear my appliance last night, so I didn't get a good sleep. So you get to compare that, and once you do that once or twice, you don't want to go to sleep without your appliance, because you're comfortable with them.
Well, this has been fascinating. I'm only going to let you off the hook because I know you promised us an hour and I don't want to go over, but I do, but I'm not going to. I just really appreciate your perspective. I appreciate that you're transparent. That's also key when you're not trying to, make it seem different than it is. It's important, I think, to help people understand. If somebody wanted to get in touch with you and just find out about how you became competent at this, you're not opposed to us posting that as
No, that's fine. I'm glad to be able to help to introduce this to people, and I know it's a tough decision, and it's a niche in dentistry that you can still do dentistry, but you're not really doing dentistry, but you're still involved, and it's a way to kind of I called it originally semi-retirement. Well, it is semi-retirement, but it's kind of a good thing to do.
There's
And how
just so
long we
much-
can do that, it'd be great.
It's just like when they say like the World War II generation, like some of that history as they die off, it's lost. Just knowing how things developed over time, because when you talk to dental students now, you're not talking to them about the things we learned about GV Black. It's like, oh yeah, GV Black, whatever. It's got to be a shorter thing because there's so much new stuff to cover, and it's like you miss understanding if you watch these things evolve over time, like what you're saying, where we started to notice things in the 2000s that it seemed as if it's sleep disordered breathing. You are in on that understanding of what it looked like and what we were missing and how we put that together, and you just can't do that unless you live it. Just telling somebody that happened that way is not the same as saying, I watched, for example, kids with autism. I mean, surely there were kids with autism.
Sure.
But something started happening, and then they start talking about people not doing floor time with their kids, right? Well, you get these mothers all going back to work all at once, and nobody's with their kids anymore, and they're sitting in a thing, and they're not going to need. And then it starts to kind of be like, oh, let's revisit that whole piece, and then it changes the way everybody does everything because somebody saw something, and it might be anecdotal, but you start to make connections, and that's what I think, especially with COVID. So much of that was.
Yeah, COVID kind of was the cherry on top, unfortunately.
Yeah.
That kind of brought everything kind of together, and everybody had to kind of stop back. I looked at career in dentistry, in the 70s, and what we did in the 70s to do just dental dentistry, taking impressions and cutting preps, and I started out doing amalgams, and then we started into composites. I mean, we don't do anything like I used to do, basically,
right.
Except you're still one-on-one with the patient, and you got to use all the tools and look at the implants that we have now. So there is a lot of opportunity to do different things in dentistry, particularly way different than we did 40 years ago, and that's a good thing. But boy, that requires a lot of effort and time and learning and cost too, because you throw in some computers and you throw in some CIRAC machines and some scanning stuff. I mean, it's
even helping
totally
them
different.
discern. One thing we used to tell our residents was just don't jump in so fast.
Yeah.
Like, don't go, I need a 6-chair office. You don't need a 6-chair office. You don't have any patients, right? You need a couple operatories, and you need to have the ability to expand that. But, they go get themselves in debt. They're already massively in debt from school.
Sure.
And then they are worn out.
And I think you're right about afraid of the younger dentists. Yeah, they don't want to do that because it's a commitment, and maybe you do have to do some DSO dentistry for a while, but don't get caught in that in the long run, because I think you need to be something else. So, but you're right. Don't do a big office. A 1 or 2 chair office would be perfectly fine when you first start out, if you're starting off cold.
You can make $6 million and have 7 dentists and 24 staff members, and by the time you get done, you still just get what the guy who's by himself gets.
Exactly.
Because it's just a matter of proportion. And we see that, we have larger practices and smaller practices, and you look at the numbers and you're like, so what you took home for all the aggravation and multiple locations, and you're like, for all the aggravation you went through, which again, if you're into that, good for you. That's energizing for you.
Well, I tried that, as I said, and I didn't particularly like that.
And that's
Later,
There you go.
very bad. I made that far
Right.
enough of me. Right?
You have to know I just love
Thank
it.
you so
Some
much.
people that just, they like that.
Oh, yeah, it
They
lights
love
their
that.
fire.
And they love to have 4 or 5 different offices. Nowadays, it's kind of common to have 2 or 3 offices under one umbrella, and certain dentists go to different bosses, and somebody's got to manage that, and if somebody wants to do that, that's fine. That's not my cup of tea.
Yeah, I think that's it. You got to find yourself.